Hi, good morning, good afternoon, good evening to everyone. Thank you so much for joining us for today's webinar on non-communicable diseases and communicable disease connections. We are so happy to have you here and encourage you to introduce yourself in the chat box. It is right on time, so we are going to go ahead and get started because we have some great panelists for you all to hear from today. My name is Liz Beyer, and I am the moderator for today's webinar. I am the Advocacy Director with StrongMinds, which is a global mental health organization working to democratize access globally for people living with depression. We know from WHO's recent mental health atlas release that there are 332 million people living with depression. And we also know that only 9% of people receive treatment for their depression. We are working to close that treatment gap by providing free, community-based, evidence-based therapy to people in low-resource settings, particularly in Africa. We provide this through evidence-based 6-week interpersonal group talk therapy delivered by trained lay providers. And we know from the course of our work on treating depression that the connection between mental health and depression and communicable disease is strong. In particular, in our work working on HIV prevention and treatment programs, we know that people at high risk for HIV are often people who are experiencing depression, and we know that treatment of depression improves ART adherence for people living with HIV and depression both. I'm really excited to be here today with this incredible panel to explore more deeply those connections between non-communicable and communicable diseases. I am serving as moderator of this Global Health Council webinar today. If you are not familiar with the Global Health Council, it is a leading member organization devoted to advancing global health priorities by uniting advocates, policymakers, implementers, and other stakeholders as part of advocacy efforts. Global Health Council hosts member-only advocacy working groups as well. These working groups help to connect people and organizations passionate about global health with resources and opportunities to take action and make a difference. Specifically, today's webinar is co-hosted by our NCD working group, which works to unite organizations focusing on improving care for people living with non-communicable diseases, including groups that focus on community health workers, mental health, clinical support, direct care, and patient and family support. We bring together a range of NCDs, including cancer, heart disease, oral health diseases, childhood onset NCDs, and mental health, including depression, and more. Our working group currently focuses on educating and building awareness around non-communicable diseases among United States government and multilateral agencies, building awareness through the investment case for non-communicable diseases among multilateral agencies, including how much money could be saved by the prevention, early diagnosis, and timely treatment of non-communicable diseases, and aligning the larger NCD community around engagement with the very upcoming 2025 UN high-level meeting on NCDs and mental health, taking place in just a couple of weeks in New York City. And it is that against that backdrop that we are hosting this webinar today. We are all living through a dramatically changing global landscape and funding, and it's time for us to be rethinking how global health architecture can understand the links between diseases and respond holistically to communicable and non-communicable diseases in the same way that people experience them in their lives. And this is particularly exciting considering that in just about, I think, 10 days from now or so, global advocates will be gathering in New York as the UN General Assembly takes up the high-level meeting on NCDs and mental health, which is a really exciting opportunity to outline priorities, accountability mechanisms, and funding to advance and promote non-communicable disease and mental health prevention, screening, and treatment programming. So with that, I'm going to give just a tiny bit of housekeeping and then hand it over to our co-host. Again, please keep introducing yourselves in the chat box. It's exciting to see how many folks we have with us today from all over the world. We ask that if you have questions for our panelists today, that you please enter those questions into the Q&A box. If you look at the bottom of your screen for the Zoom window, there is a box that says Q&A. please enter your questions there and not in the chat box. If you enter them in the chat box, we may miss them. So please ask questions to our panelists. They're excited to engage with you, but add those in the Q&A box. This webinar is also being recorded, and the recording and any PowerPoints shared by our panelists today will be shared after the event with anyone who registered to attend. So with that, I am thrilled to introduce Cary James, who is the Chief Executive from the World Hepatitis Alliance, which is our co-host of this webinar today. World Hepatitis Alliance are GHC members, and he is a former advisory group member to the Civil Society Engagement Mechanism of UHC 2030, and the former Global North Civil Society Steering Committee representative also for UHC 2030. We're thrilled to have you here today, and we are thankful to the World Hepatitis Alliance for co-hosting this webinar. So over to you, Cary.
Thank you so much. And thank you everyone for attending. It's a real thrill to be with all of you today for this very important and timely topic. So I'm going to try to share my screen, which is always a bit risky. Here we go. So united against communicable and non-communicable diseases. That's the topic. And just quickly, just so you have a little bit, a little bit about the World Hepatitis Alliance. If I can get this to advance. Oops. There we go. So World Hepatitis Alliance, we're a network of community-based organizations in about 125 countries, all working for hepatitis elimination. But many of our members are very community-focused and looking after the health of their community. So they're not just working on hepatitis, they're also working on TB, and they're also working on HIV or providing diabetes support. So I think the kind of the division between communicable and non-communicable diseases is quite artificial, and maybe is unfortunately a product of kind of the global health architecture as it's developed over the last 20 years, and where the funding's been coming from, and maybe some competition for that funding. But I think throughout this webinar, we'll see that we're not really talking about two different things. We're talking about things that affect individuals. And they're not compartmentalized. It's just part of their health and part of their well-being. So as we are kind of forced to think about them as separate, really, we should just be focusing on individuals and individual health rather than these kind of artificial designations. So we know that many communicable diseases actually cause what's being classified as a non-communicable disease, like cancer, for example, is a NCD, is classified as an NCD. But we know that most liver cancer cases are caused by hepatitis, which is a viral infection. The same with HPV is the major cause of 6 types of cancer. Most people know cervical cancer, but also anal cancer and other forms of cancer. And also things like strep can lead to rheumatic heart disease. So it's so while we're talking about NCDs, then we're also talking about the causes of those can be communicable diseases as well. And the preventing NCDs, when we're talking about tackling NCDs and what's being done, work on communicable diseases contribute to that, because we know by preventing and treating hepatitis, that will reduce liver cancer deaths globally. Same is true of HPV. If through vaccination and screening for HPV can identify precancerous cells, can then be treated to actually prevent cancer cases. And the same things around antibiotic treatments around strep and rheumatic fever. So these aren't two things. We're talking about things that are not only connected, but are also all part of the same system. So they really do have to think about them together. And then, of course, there's what's called comorbidities. So that's if you have 2 different conditions and how they interact in your body and maybe make them worse or maybe make you more likely to acquire things. So we know that people living with diabetes are 2 or 3 times more likely to develop TB, and they're more likely to have hepatitis B or C. Like some of this can be causation, some of these can be physical changes in the body that may make you more susceptible to an NCD, or may lower your immune system, which may make you more susceptible to an infectious condition. But they can also be about more kind of systemic causes, because we know that a lot of TB and HIV, hepatitis, these are conditions that are more common in people with lower economic attainment, people that are from marginalized communities that perhaps don't have access to health services, some ones that can be kind of ostracized from communities as well. So it's not just, there's just sort of many factors around the comorbidities rather than just kind of physiological. Yeah, and we know that the two of them together can make both of them even worse. So just some more examples. People living with HIV have an increased likelihood of cardiovascular disease, depression and mental health problems, and diabetes. And again, people living with TB, Hep B, or Hep C have an increased chance of diabetes. No, these are just like tiny little examples. It's also people who live with hepatitis are also more likely to experience poor mental health. So these are just a few examples. I hope we hear more in the chat, and I'm sure we're going to hear more through the panel about other examples of all of these things. So, please, I'm sorry if I've left your particular area of work out. But this has been such a big a piece of work for us at the World Hepatitis Alliance for a long time now, and it's all kind of coming up to a head this year with the high level meeting on NCDs. So earlier this year, we released a white paper around beating cancer through hepatitis elimination, which we launched at the World Health Assembly. There's a barcode there if you'd like to scan it and download it, but we'll also put a link in the chat. And just a few things. I mean, the data is startling. I mean, hepatitis is one of the few, these big communicable diseases where mortality is actually increasing. And so are deaths from liver cancer. But despite this, awareness and action by health departments or by politicians are low. And it's also often left off of health plans, and it's often left off of the global health agenda. And even when there are interventions in place, they're often not reaching the people who are most in need. So kind of what I mentioned before, hepatitis is often disproportionately affects people that are marginalized from societies. They may not be comfortable accessing mainstream health systems. So it just contributes to this growing problem that we have. And there's many calls to actions in the white paper. I won't go through these in too much detail because I want to get to the panel. But I think the headline one is to integrate hepatitis testing, treatment, and vaccination into national cancer programs to decrease the incidence of cancer, increase early diagnosis, and reduce mortality. So this is something that's so obvious. It's such a easy thing to be integrated into programs, and the potential benefits to individuals and the health systems are so great. It's really a no-brainer, really. But then we also, need more awareness programs, and integration in primary healthcare is absolutely essential. And obviously, this is a big topic now as well, with all the changes with funding from donor funding. That the issue of integration with primary care for HIV, for TB, for malaria. This has been something that's been increasing in profile over recent years, but it's even going to accelerate even more. And just very briefly looking at the HLM and NCD. So the political declaration, which hasn't been officially released, the final version, but from the last version before the silent period came, there were really 3 paragraphs that really talked about this kind of crossover between communicable and non-communicable diseases. Paragraph 48, which actually uses that language and talks about HIV, tuberculosis. Paragraph 52, talking about cervical cancer and HPV, which is fantastic. And paragraph 54, which is about liver cancer, which includes hepatitis testing, treatment, and vaccination, as well as the screening and management of non-alcoholic liver disease, which is also an NCD. So I think there's lots of things happening. I think it's great that this discussion has been growing and growing, and I'm really looking forward to hear from our panelists now. So yeah, that's the QR code for the white paper, and thank you very much.
Thank you, Cary. That's a great foundation going into our panel, particularly about the ways that the division between non-communicable and communicable disease is so arbitrary, and people's real lives don't reflect that division. So thank you for that. I'm thrilled to introduce the panel. If I can ask you all to turn on your cameras just to give a quick hello, and then you can turn them back on when you're speaking later. So today we are joined by Shaibu Issa from the World Hepatitis Alliance AFRO board member and the director of the Tanzania Health Alliance. We have Dr. Dupe Coker, the Assistant Dean of Clinical and Translational Research and Associate Professor at the University of Pennsylvania. We are joined by Kate O'Brien, a TB survivor and advocate with We Are TB, and Lillian Kreppel, the CEO and co-founder of HPV Cancers Alliance and a cancer thriver. We are really excited to have this mix of experts and lived experience champions here with us today. So thank you all for joining us. And we are going to start by, I'm going to hand it over to Shaibu Issa to talk to us about hepatitis and liver cancer.
Okay, thank you very much. Good morning, good afternoon, and good evening to all people attending in this webinar. My name is Shaibu Issa. I'm lived experience with viral, where it was in high school, where my brother felt a stomach ache for a while and decided to go for the checkup, and the result showed that he's affected with viral hepatitis. So then he advised me to do the same. So I went, and the result also showed that I had it was positive hepatitis B surface antigen in my blood. So that's where stigma, discrimination, and social isolation I started to face from the old people surrounding us, including teacher, my fellow student, and everyone who knew that we are affected. I remember for the first time, teachers and some doctors came at our school and announced like, your fellow student is affected with deadly viruses, so you must get distance from them. So that is amplified the stigma to the student. We've been isolated in all party of the school life. We went for the first. We admitted at hospital where it was the same experience of stigma and discrimination to the doctors and nurses, and most of them they refuse even to touch our body for fear that will would transmit the disease to them, and it reached a point we have been kept into a very small darkened room and forcibly tested HIV for believing that if you have viral hepatitis, automatically you have HIV. So we face maximum stigma, but this is the point. For the first time, my brother get a diagnosis with smallpox into her liver that indicated a cirrhotic liver. So after that, we got a referral to the Muhimbili National Hospital in Dar es Salaam, where the treatment we started treatment, and it was very difficult because cost of treatment is very high, and most of the checkup and diagnosis are not included into health insurance. So that's where our parent is supposed to solve each and everything they produced as a land, a livestock, and everything they had to handle cost of the treatment, although it was not enough. So I started to fundraising from the people to manage the cost. Also, it was very difficult. So at this time, we face the depression because it was a schooling. So we're supposed to be at the schooling, but we're supposed to be at hospital at one time. So very depressed. Everyone around us refused even to get close with us because of this situation. So as and our parenting, we were into the situation we never expected, especially a situation of stigma that we never witnessed at the previous. So soon we back at school for the last examination, and we succeed to pass our last exam, and we enrolled at university. So the 3 years of university, it was the same. So according to the situation, we refuse to expose our condition because we refuse, we fear about the stigma. At the stigma we face at secondary, we refuse, like, if we could expose our situation here, it will be the same as in secondary school. So we live there with high depression because we could not afford the cost of treatment. And another challenge that we face, it was the distance from Dodoma University to Dar es Salaam. We faced to cover the cost of treatment. And I remember at that time, our parents were not able to manage any kind of cost. So that's what make us to stop even to attend in hepatology clinic when we required it. So at this time, as I told you, that my brother was detected with a small potty into her liver. It was a cirrhotic and it was a progress. So with a delay of over 3 years not attending at the clinic, it means that the condition was progressing until it reached a time we graduated at University of Dodoma, and a few months later, my brother faced a critical situation where he admitted at Muhimbili again. They realized that he developed the liver cancer, chronic stage of liver cancer, I mean HCC. So that was another stress for me, thinking I'll be the next. But I strive again to fundraising to the people, and that's where I decided to go at university again and to tell them the situation that we lived with this disease for a while, but we fear to expose because we are afraid about the stigma, because there is a lot of misinformation on this disease. So after that, fundraising, but we could never be able to get what he wanted, but also the level and the quality of treatment. It was not at that effectively. So in 2021, April,
Sorry,
my brother
Shaibu, we're
died.
almost out of time. If you can wrap up, thank you.
Okay, thank you very much. Okay, so the connection between communicable disease, hepatitis, and non-communicable disease is hepatitis, if it's not managed or treated, can be shifted into the liver cancer, and over 56% of all cancer deaths are caused by viral hepatitis B, and mostly those we are not managed or treated timely. Thank you very much.
Thank you, Shaibu, for sharing your story with us for you and your brother and connecting that back to the importance of early detection and treatment. Now I will hand it over to Dr. Dupe Coker to talk about oral health and HIV/AIDS. And as a reminder to all of our attendees today, if you have questions for Shaibu, for Dr. Dupe, or for any of our panelists, please add them in the Q&A box. We will not see questions in the chat box, so please enter your questions in Q&A. We would love to hear from you. So over to you, Dr. Dupe.
All right, can you hear me? Can you see my screen?
Yes, we can.
Okay.
Yeah.
Hello, everybody. Such a pleasure to be here. I am so honored to give this quick introduction, or they call it intervention. Just again to give a peek into that interplay between communicable diseases and non-communicable diseases. And this is a very classic example. That's the story of my career, overlapping HIV with oral health. So I'm a dentist, I'm an epidemiologist, I'm also an infectious disease practitioner, public health practitioner. But I have the privilege, I call it privilege, of being able to lead a cohort of kids and mothers living with HIV in Nigeria, and also a group in Philadelphia as well. So I have that beautiful opportunity to look at two perspectives. So what really drove me into this idea, I'm a dentist, but I was working with a public health program. And just like Shaibu, the examples that I will give you today are just to kind of tell you where the passion and the drive is coming from. And I was focused on HIV because that was the public health pandemic at that time. And I was observing an increased risk of dental caries in the children that I was kind of supporting with HIV care and treatment in Nigeria. And this was just after my master's in public health. So I just want to give you that kind of something to think about as you navigate your world about oral health. I know HIV, many of this in this room already kind of know the importance of caring for people with HIV, but that is sometimes overlooked when it comes to oral health. So I would like to kind of share a bit about, if I can navigate my slide, about why oral health is important. And I'm just giving you a perspective from the work that I do with microbiome. But honestly, not only just the microbes, there are other things that could be instrumental to how the oral cavity impacts other parts of the body. We know, and you must have heard, of course, you've also heard from Cary about rheumatoid disease, heart disease, right? The bacteria he mentioned, the streptococcus that you mentioned, is a resident bacteria in the mouth. You must have also heard about the brain in terms of we see certain kinds of bugs in the brains of Alzheimer's patients, dead patients, the postmortem. Also, we've heard about what's happening with respect to colorectal cancer. We're seeing certain bugs that are resident in the mouth, in the colon, and it kind of drives colorectal cancer. So I'm just kind of giving you examples of how we should be paying attention to the mouth.
Dr. Dupe, we can see your slides, but they're not advancing. So you may need to put it in presentation mode.
Okay.
Sorry to interrupt.
No, it's okay. What can you see now?
We are seeing the acknowledgements slide and the bar of mini slides on the side.
I'm going to have to stop and share again. It's not.
Yeah, no problem.
I apologize.
No, that's fine. It's not a webinar if there's not a tech challenge.
What can you see now?
Perfect. Yep, we're on the first slide now.
Okay, so I was describing this, sorry for everybody who I was describing the microbes and how we should be paying attention to the oral cavity. So I'll move on from here. So how does oral health really impact systemic health? How? Like, this is exactly what it is that I was trying to explain to you. There are many ways, but one thing I want you to leave with is think about you drink about 1 liter of saliva every day. That's a lot of saliva. And it goes to the gut. The mouth is the first part of the gut. And so you can imagine anything you ingest and you chew is the mouth that kind of holds space for it. Another interesting thing that maybe many of you don't know is the mouth is home to a covering called the tooth enamel. That's the strongest bone in the body. That casing is the strongest bone. So if something destroys that bone and it's causing decay in the mouth, we should be paying attention. That means something is happening in the body that can resist that intervention of decay, right? Or that progress of decay. So I want to just kind of leave that for you to think about oral cavity not being siloed from systemic health. Again, I don't see patients with only teeth. I see patients with, I don't see teeth. I see patients with teeth, right? They come into the clinic with the whole body, but we also look at the mouth, right? So there's no tooth that just walks into my office, right? They come with the whole body. So something to pay attention to as we navigate this overlap that we're describing today. I don't need to tell you this. This is going to get bigger, as many of you have already alluded to in this webinar. With what's happening right now, this rising number of people living with HIV, as well as those who are acquiring it. And it's going to increase given what we know, the gap in funding right now. But I wanted to highlight a little bit about the syndemic nature of HIV. So, and this kind of ties nicely with what our topic is today, is that it's not siloed. Yes, HIV, people living with HIV have a heightened risk for conditions, but there's a lot of overlap. We have things like behavioral, socioeconomic status, access. Somebody mentioned earlier today, biological factors, which I'm describing with the biology and the microbiome, but there's a lot of things that happen with, you mentioned stigma earlier today, you heard about stigma, you heard about, access to care earlier with Cary. So there's a lot of things that once you're living with HIV, there's an overlap. So obviously there will be a syndemic response in this population. I also wanted to tell you that with work that I do, there's a increased risk of dental caries, and this is what I was going to highlight in terms of therapy. Either therapy or the HIV infection increases the risk of dental caries, probably because of chronic inflammation. It could be the salivary flow is impeded, tooth development is impeded. Diet is also, it's hard to kind of chew or have good health, good healthy choices when you don't have good teeth. Of course, and time, the longer you're on therapy, the longer you are in care, you increase the risk of dental disease. So I want to end with the fact that oral health is often overlooked. Pay attention to it. I think many of you already agree with me, but we should be paying attention to it as a global community, because it impacts oral health, overall health. It also impacts systemic health. I also think that we should start thinking about integrating care systems. Somebody mentioned it earlier today, as well as training workforce and thinking of innovative ways for sustainability. Not just putting a program out there. We need to actually think about how we can make it sustainable. And I just want to leave you with the fact that I don't do this alone. I have a huge number of people that work with me. And I think that's really the bane of this talk, is that we can't do it on our own. We have to do it together. And so thank you for listening.
Thank you so much, Dr. Zupe. That's really an important message about the connection between oral health, systemic health, and how, again, we're hearing so strongly from everyone that NCDs and communicable disease do not exist in the silos we've put them in. So thank you for that. And with that, I will turn it over to Kate O'Brien, who to talk about TB and autoimmune disease, and talk to us a little bit about what they're doing at We Are TB. Over to you, Kate.
Awesome. Thank you so much. I'm also going to share my screen real quick. I hope you guys can see this. We'll do a little play from start. And I want to thank you guys all for having me here today. We Are TB is a group of people who have had tuberculosis, like me, in the United States. And we're generously hosted by the National Tuberculosis Coalition of America. So I'll tell you a quick little bit about my tuberculosis story. I have these slides are really just because I'm like a yapper and I need to keep myself to time. So, but it's just so funny because I look at this picture, and when I took this picture, like I thought like I was looking really good and like good enough to take a picture, but man, I look horrible. So I'm not sure when I got the tuberculosis bacteria. Like most people, I just breathed it in at some point in my life. And tuberculosis has like a latent and an active kind of phase. So when I first breathed in and had tuberculosis infection, I didn't know that I had anything kind of living or growing in my system. But when I started trying for a second pregnancy, all of a sudden I started feeling really, really bad. And what can happen is if you have something changes your immunity, like a pregnancy, a latent tuberculosis bacteria that's kind of just chilling in your body and controlled by your immune system can wake up or activate or become tuberculosis disease. So all of a sudden, I just started feeling so bad. And I went from doctor to doctor, just kind of trying to figure out what was wrong with me. And I'm very blessed and lucky to have, decent health insurance. And I had a lot of great doctors at my disposal. But when I went to them, I really couldn't get a sense of urgency, and I really couldn't get any answers as to what was wrong with me and why I was getting sicker and sicker, why I was having night sweats, why I had no desire to eat, I had no energy. I would basically wake up every morning and cough and cough and cough. Eventually started coughing up blood. I just didn't want to do anything. I didn't want to eat. I didn't want to go anywhere. And I was so worried about my baby. But because I was pregnant, really my doctors didn't see anything else. They explained all my tuberculosis symptoms away with the pregnancy. Maybe the night sweats were like hormones. Maybe my desire to eat. Sometimes that can happen with pregnant women where they just don't feel well. They even explained away the coughing up blood as me having like, gastrointestinal GERD or something like that. And that kind of bother the, like kind of like acid in my stomach bothering my throat. Eventually it got so bad that I was hospitalized with severe dehydration. And they tried to give me an intubation to see, and give me an endoscopy to see if the damage from the acid reflux in my throat was really a problem, but it was tuberculosis. So when I went to, during the endoscopy, when I couldn't be intubated properly, I finally got this chest x-ray and they found out that it was TB. All during my treatment, even though I was coughing up blood and I was treated for pneumonia several times, nobody wanted to give me a chest x-ray because I was pregnant. And that would have solved the problem a lot earlier. So I'm telling you this story just so that you guys kind of can see that one health condition kind of overshadowed all of my treatment. And while the pregnancy is definitely what made my condition go from like a latent tuberculosis infection to active tuberculosis disease, what was causing my symptoms and what was causing my problems was tuberculosis. It wasn't the pregnancy. So sometimes doctors really can't see beyond one condition for another when they're treating something. And care really is very siloed. And that's why I almost died of tuberculosis and almost lost my baby. But I didn't lose my baby. He's now 10 years old and he's at school right now. But I'm very lucky because a lot of women do lose their babies. And a lot of people die of tuberculosis. It's the #1 infectious disease killer in the world. So the other thing that made my treatment a little bit difficult is when you're pregnant, your liver has a lot of changes. And so my drug regimen was a little difficult. When I finished tuberculosis treatment, I started working with a group called We Are TB that I told you about. And we do support groups. And we have a lot of people that come to our support groups who have autoimmune conditions, things like diabetes. We have MS, lupus. We have all sorts of different conditions in the group because just like the pregnancy, people who have autoimmune conditions are more at risk for a latent tuberculosis infection to activate, right? People have to balance the treatment of an autoimmune disease or another health condition with their tuberculosis treatment. And it can be very difficult because we'll have an infectious disease specialist that really gets antibiotics and really understands tuberculosis. And then maybe you have another doctor, a neurologist that really gets your MS. Maybe you have a really good doctor that understands your rheumatoid arthritis, but they're not the same person. And so the person in tuberculosis care is left in the middle to try and navigate how these two things work. And it's very difficult. Frequently, if you have an autoimmune condition or if you have something going on in your body that means you have to take a biologic or a medication that lowers your immunity, if you're in treatment for an infectious disease like tuberculosis, you might have to stop your biologic for part of treatment or the whole thing. So then you're dealing with the symptoms of the communicable disease, the symptoms of your condition that needs the biologic, and any side effects of tuberculosis medication. And side effects of tuberculosis medication can be very, very difficult. When you're finished with tuberculosis treatment, there's no one kind of a diagnostic test that makes you say, oh, you're clear forever. Like when you have TB, you still always will test positive. So when people have to restart a biologic, it can be very nerve-wracking. Everyone who's had TB treatment always wonders, will it come back? And now when you're taking a biologic, that can be very nerve-wracking to kind of wonder if the TB will really come back because now you're taking something that will lower your immunity. That kind of navigation between I'm at time. The navigation between the two continues post-treatment. If you're in tuberculosis treatment or you know somebody who is, please reach out to We Are TB. We do free confidential support groups in English and Spanish. Thank you so much. I'm sorry if I went over.
No, thank you, Kate, and thank you so much for sharing your personal story and sharing the support groups with folks that may need that. Thank you so much. So I'm going to hand it over to our last panelist, and then we will go into question and answer. A reminder that if you have questions for Kate, for Dr. Dupe, for Shaibu, for Cary, or for Lillian after her remarks, please add them in the Q&A box. We will not be taking verbal questions, and we may miss it if you put it in the chat box. So please add it to the Q&A. So I'm going to hand it over to Lillian now to talk a bit more about specifically the connection between HPV and cancer.
Audio. Okay, sorry about that. Thank you so much. Hi, everyone. I'm really happy to be here. Thanks for having me. I am the CEO and co-founder of HPV Cancers Alliance and a cancer thriver myself. Today, I'm going to talk to you about the very real links between communicable diseases and non-communicable diseases, specifically through the lens of HPV and cancer. So there are a lot of people like me. I was diagnosed with stage 2 anal cancer caused by HPV. Like many people, I had no idea HPV could cause this type of cancer. I had heard about cervical, but I didn't know about the others. I was dismissed by my first doctor, but I knew I wasn't okay. So I knew I had to advocate for myself. I went to another doctor, finally received a proper diagnosis, and then endured the grueling chemotherapy and radiation. But I made it through, and it fueled my mission to do something, ensure that others will not have to suffer the same way. HPV, human papillomavirus, is the most common sexually transmitted infection in the entire world. Nearly everyone who's sexually active will contract a strain of HPV at some point in their life. In most cases, the virus clears on its own, but sometimes it doesn't. And when it doesn't, HPV can lay dormant in the system and reemerge as cancer. HPV causes 6 types of cancers: cervical, anal, penile, vaginal, vulvar, and oral pharyngeal. And there is a direct and powerful example of how a communicable infection can evolve into a devastating non-communicable disease, sometimes decades later. Take oral and throat cancers, for example, in the US alone. HPV now causes more than 70% of oral pharyngeal cancers. We're seeing younger and younger people, even non-smokers, never drinkers, diagnosed with these cancers because of a virus they contracted many years earlier. Or cervical cancer globally. Cervical cancer is almost entirely preventable, yet it remains one of the leading causes of cancer death in women worldwide, all because HPV infection isn't addressed early enough through vaccination, screening, or treatment. Though cervical cancer has been nearly eradicated in Australia due to government-funded vaccination and screening programs, there's a lesson to be learned. HPV and related cancers are a global public health crisis made worse by inequities in access, education, and provider engagement. At HPV Cancers Alliance, we hear stories every day. Parents losing daughters to cervical cancer where vaccination and screening wasn't available. Men in their 40s and 50s shocked by a throat cancer diagnosis. And LGBTQIA plus individuals too often left out of prevention messages. These aren't isolated cases. They reflect systematic gaps, limited awareness, stigma, and a lack of provider initiative in discussing vaccination with their patients and participating in shared decision-making. Too many lives are lost simply because opportunities for prevention and early care are missed or ignored. The good news is that we have tools. HPV vaccination is the golden ticket to major cancer prevention. Screening and early treatment save lives as well. But we must close the gap between what's possible and what's actually happening through education, policy, and by elevating voices of lived experiences. While we understand HPV as the bridge between communicable and non-communicable disease, we not only prevent cancers, but we reduce stigma and empower communities to act. And here in closing is a fact. If everyone received the HPV vaccine, we could eliminate 5% of the world's cancers, which means 1 million cancer diagnoses, and nearly 500,000 deaths per year. Like that's a statement. So if anyone has any questions or wants to reach out to me, feel free to reach out to me at hpvca.org. And my name is Lillian Crapel, and I'll be happy to talk to you as a patient who went through this and came out on top.
Thank you, Lillian, so much for sharing your personal story as well, and for sharing so much important information about vaccine preventable cancer. Really exciting to hear from all of our panelists today about the work they're doing and their personal experiences at the intersection of communicable and non-communicable disease. So we are now going to move into our Q&A. So I will ask our panelists to turn their cameras back on, please. There are so many great questions. We may not have time to answer all of them. Panelists, if you see any in the open section that you want to type an answer to, feel free to do that. But we are going to kick off with a question really to everyone about, one of the messages that came through so clearly in all of your remarks, from Cary's opening to all of your interventions, are that this kind of artificial division between communicable and non-communicable diseases is not really in alignment with the experience of patients and with the reality of how people are living in this world. So I'm wondering if you can each talk a little bit about what are some of the systemic barriers that are preventing health systems from moving forward with more integrated approaches to NCDs and communicable disease, how we can overcome those, and specifically if you have any examples of integrated models that are successfully improving outcomes and kind of operating holistically. So we will start with Dr. Dupe.
Can you repeat that? But I think I'll start with it, and then you can tell me anything I missed. Sure. But the thing about it is, we for sure have good examples out there. I know that we all kind of not complained, but we kind of shared challenges. I do want to say that there's some great work out there. For example, I know that in Arizona, there's this medical and dental integration. I mean, I'm talking from my own field, right? There's a medical dental integration happening in many states in the US. I know with respect to HIV, global health, there's been a lot of case coordination where they're providing referrals to dentists. I know, for example, in Penn, everybody where I work, everybody who is going to be receiving chemotherapy has to go to a dentist to get a clear, like to get like some kind of clear bill of health before they start chemotherapy, and that's beautiful. So I think while I know that we have a lot more work to do, there's a lot of things that we can actually learn from. But going back to the question about barriers, it's really financial. I mean, everything is siloed because the money is coming in different pockets. You have the HIV money coming in a different pocket. You have the dental money coming in a different pocket. You have dental school, you have medical school. I mean, that's already inherently in my work, already kind of puts a silo right there because everybody seems to be separate. So that's what I would say. I say we need to start working together. I think from the foundation of funding, foundation of actually making sure that the funders or the sponsors tell us to be united. Once there's a mandate from the sponsors, it can definitely build to be some alliance and some referral systems.
Yeah, thank you so much, Dr. Dupe. It's great to hear examples of how that's working well. Shaibu, do you have anything you want to add about how we can create a more integrated system?
Yeah, so first of all, I think in many countries, political decide sciences, and that's where I can say in making this possible, we need the political will. For instance, the big problem we have in hepatitis elimination is just because many countries are committed. They are pledged to eliminate it, but they are not acted. Unless we have many infection and death in many countries, that is going silently, and because politicians are not really decided. For instance, here in Tanzania, we have a hepatitis guidelines that are not signed for so many years. It means that the politicians are not given priority to this disease. The best example of integration, we have what we call triple elimination of HIV, hepatitis, and syphilis. So this integration of HIV, hepatitis, and syphilis can reduce mother to child transmission of viral hepatitis, which is in many countries are not taking it as something very serious. For instance, here in Tanzania, pregnant women are only getting tested for HIV and syphilis and left behind to viral hepatitis. But with evidence, hepatitis are more contagious than HIV and syphilis. But pregnant women are not. So many children are born with this problem and are more likely to develop liver cancer than even adults who are got infection from the birth. So I think we can mitigate this problem first for advocates. Advocates will raise the profile of this disease. For instance, we have very best example from Egypt. Egypt successfully to eliminate HCV. And it's because first the government accepted that this is public health challenge. So they started a national campaign. It was the mass testing, mass awareness. So everybody's aware. People cannot take action to the things they are not aware with. And that's the big challenge we have in viral hepatitis, that people are not aware. Over 350 million people globally living with this problem. But very few percent of people who are aware that hepatitis are killing more than malaria, HIV, and even TB. So to tackle this problem, first we need to make people aware and to inspire government to take an important action to test, vaccinate, and treat people. Thank you.
Thank you. Yeah, thank you, Shaibu. That's really important. And it's great to hear another example of how some of that integrated approach is working well. Kate and Lillian, I want to ask you guys actually a different question. There is a question in the Q&A about, I think particularly in the United States, but not only here, there are pushbacks against sort of addressing some communicable diseases and infectious disease because there's an argument that we should be focusing on chronic disease. What would you say? How can you push back against that? How can we be effective advocates for responding to both? Since both of you are kind of working from that lens, maybe we'll start with Kate and finish with Lillian, and then I'll hand it to Cary at the end to wrap us up before we close out.
Sure. So, I think it's just so funny because like this urge to silo, right? Like this urge to look at, these problems in a way that just doesn't exist. This urge to separate things, if we take care of one, this first, then this. It's just not how anything works, like literally anything. And, I loved what Dr. Coker said earlier about like, I don't see teeth, I see patients with teeth. Like that's this whole webinar, right? So like, I think that like funding it that way doesn't make sense either. Making us fight for scraps for different, urges and issues doesn't work either. I think, we really need to band together because there's no single person that only has one health thing their whole life. Like we're all it just doesn't make any sense. That's my answer. It just doesn't make any sense. And I would just argue that, people are individuals with like a collection of elements to their bodies, and they change over time. So even if you think something might not affect you at one point in your life, it might later. Just like I never thought I could have lived my whole life with latent TB probably if I didn't get pregnant. Like you never know. Anyway, thank you, and hand off to Lillian.
Yeah, I think that can you repeat the question one more time? Just
sure. So there's a question. Yeah, there's a question in the Q&A about, let me scroll back up to it sort of specifically, but particularly around, that global health is under attack. And I think particularly we're seeing in the United States, although I'm sure elsewhere, that support for that attack is coming partially from people who are really concerned about chronic diseases and feel that we're not doing enough to fight that and want to shift focus away from infectious disease towards chronic disease. Is there, a stronger message, or how can we push back against that idea and kind of uplift how all of these things are connected? And we need to both think about preventing HPV as we try to, address and prevent cancer as well.
Yeah, I think that patient voices are like the way to go. And for example, with what we do, it's, like I said earlier, it's not just anal cancer, but, there's oropharyngeal, there's even something called recurrent respiratory papillomatosis, which people don't know about, caused by the HPV virus, which can end up into lung cancer. We're not in competition, which is the good news. All of the HPV cancer organizations, we work together. And I myself, we go to DC every year and we do a day on the Hill where we speak to, members of the House and also the Senate. We actually had the Prevent HPV Cancers Act almost signed off on, and then somebody in the Republican Party took away her vote for that recently because of what's going on. But I just think just to keep going and just, when HPV is more common than COVID, it is like everybody gets it. It's like touching glitter. So it's not, like everybody can get it. And it's nothing to be embarrassed about. You didn't do anything wrong, but you need to know about it. And when I talk to people, like women, and they have no idea why they're going to their gynecologist. Like, why are you getting a pap test? Don't know. Why? Why don't you know? Why did my new medical primary doctor, when I asked her why her 13-year-old kid doesn't have the HPV vaccine, and she said to me, "Oh, well, she's not sexually active." I mean, you got to put your seatbelt on before you get in the car. So, I actually went through this whole thing with her, but I myself am on a whole campaign to speak with each and every one of these doctors to get them going. The providers, it's a lot of them, HPV is not on their radar. If I listened to my doctor who said I was okay when I knew I wasn't, I wouldn't be here.
Yeah, thank you so much. That's so true. I think the power of individual stories and champions, and particularly lived experience champions, is so powerful in that continuing to fight back. Shaibu, I have time. If you can keep it really, really short, I can give you the last 20 seconds before I hand it back to Cary.
Okay, so I want to insist based on the people with lived experience and the powerful tools to drive provide change as we carry the reality and the real feeling. So lived experience is totally will drive the impact of vaccine and awareness. For instance, we are deeply talk about HPV and HBV, which is what we have vaccine in all of them. So the people with lived experience will insist vaccination that will avoid the spread of all those diseases. Thank you.
Yeah, absolutely. That's so true. The lived experience speakers and champions are so important, and such an important reminder to folks leading programs and creating webinars and designing panels to make sure that we're having our lived experience experts and champions at the center of everything that we're doing. With that, that's a great transition, Shaibu. I want to thank all of our attendees today for joining us. I want to really, really thank our panelists for sharing both their expertise, their lived experience expertise. It's so powerful to hear from all of you. And your message is so strong and so clear that this connection between NCDs and communicable disease is there. And we need to recreate and reorient our systems to address people holistically. So I'm going to hand it over to Cary to give us kind of a final closing, including some comments on how this all ties back to the high-level meeting in a couple of days.
Sorry, in 1 minute. I mean, you guys have been so eloquent. I don't know if I have too much to add, but I think that, the high-level meeting is coming up in a couple of weeks. For those of you who aren't going to be in New York, there's loads of content online. We'll be hosting a webinar around the connection between liver cancer and NCDs on Tuesday morning, which will be live streamed. I think someone's going to put a link in the chat. I know GHC is doing a session, maybe not on this, but on other things, but there's a few other sessions. So please just stay engaged in the conversations, keep banging down the walls. These are completely artificial divisions, which you're absolutely right, Kate, is down to funding, not just on a national level, but on a global level. And unfortunately, we end up in a world where in countries that have been getting a lot of donor support, they have a communicable disease response, which is being managed by international organizations, and a NCD or chronic disease response being managed by national health systems, and the two don't speak to each other. But all of these things are going to have to change now. So I mean, I really, severely regret all the hardship being caused by all the disruption in aid and aid funding. But if we can think about it more holistically, to put the levers of power more with the people that are closer to the problems, maybe we can find some solutions that are more sustainable going forward. So thank you all very much. Thank you for your sharing your experiences, your commitment. And it's been a real honor and a pleasure to be a part of this today. So thank you so much, and we'll see you all again very soon.